The following podcast is part of a certified educational activity titled Cracking the Code of GBA1-Associated Parkinson's Disease and Lysosomal Storage Disorders, Transforming Diagnosis and Management. Access the entire activity and complete the post-test at peerview.com/GWQ860. Downloadable slides and practice aids are also available.
For joining this educational activity on Gaucher's disease and GBA1-Associated Parkinson's disease. Our talk today is called Cracking the Code of GBA1-Associated Parkinson's disease and Lysosomal Storage Disorders, Transforming Diagnosis and Management. And our goals today for this talk are the following. First, we would like to describe the molecular and genetic mechanisms and the clinical presentations for Gaucher's disease and GBA-associated Parkinson's disease. We would also like to touch on the latest evidence on screening, diagnosis, and treatment of GBA1 mutation-driven diseases. And then finally talk a little bit about the team-based approach that is so important to provide comprehensive care for patients with Gaucher's and GBA Parkinson's disease. So let's get started. Just to set the stage, it's important to remember that the lysosomal storage diseases comprise a large family of inherited disorders, about 70 individual disorders, of which Gaucher's disease is a member. Collectively, the lysosomal storage diseases affect about 1 in 5,000 live births, but individually, each of these conditions is relatively rare. Now, interestingly, over the last few decades, it's been noticed that the gene that causes Gaucher's disease, which is GBA, a gene that encodes the protein glucocerebrosidase, is also a risk factor for Parkinson's disease. And it is now recognized that both Gaucher's disease and Parkinson's disease probably shared molecular mechanisms. Now, interestingly, we now know that many patients with Parkinson's disease are diagnosed with Gaucher's disease after their diagnosis of Parkinson's, when they actually have both diseases at the same time. And then it's really important to understand that because of these shared molecular mechanisms, some cases will be recognized much longer after they have received the diagnosis of Parkinson's, which is why, as we'll talk later in this talk, it is so important to consider genetic testing for patients who might have this condition.
So my diagnostic journey actually began many years ago when I was a young child. And the first thing I had was many bloody noses. So, pretty much as a teenager, I had bloody noses, anemia, and broken bones, which is exactly what you want as a teenager. When I returned back to my hometown of Chicago after college, a regular blood test showed that there was the counts of the blood tests were very off, especially the platelets were very low. They were below 80,000. So off I went, and I got married a few years later, and my husband and I decided to have a child. And so I got pregnant, and I did an Ashkenazi Jewish screening panel after I got pregnant, and the doctor called and said, "You need to come to my office so we can talk." And of course, I was type A, I wanted to know right away. I was like, "What's wrong with the baby?" But instead, he told me that I know that I was homozygous for Gaucher disease. So, of course, that made total sense. It all flashed back. Absolutely, I was homozygous for Gaucher disease. We then tested my husband, who turns out he's a carrier because I married a nice Jewish boy, like my mom said. And following that, the baby was just a carrier. I did another test for baby number 2, and we found out shortly after that baby number 2 is homozygous for Gaucher disease. So what that meant is that we knew our son, our second son, was going to have Gaucher, and that's a really, really hard thing, because it's all of a sudden I did something. I gave my kid a disease, and he's not even in the world yet. So it was really hard to hear. I mean, we completely knew that there was a 50% chance. So it's not that, we weren't thinking about it and we didn't know, but it's still, hearing those words were really hard. But at the same time, it was able to give us control of the situation, which I didn't have, and many families don't have, because we knew what to expect. We knew that there's treatment, and we knew how to handle it. So that was the next step.
So from this point on, we're going to be talking about the diagnostic dilemma, unraveling the pathogenesis of lysosomal storage diseases and other neurodegenerative disorders, with an emphasis of Gaucher disease. Gaucher disease is the Most common lysosomal disorder is caused by the deficiency of the lysosomal membrane enzyme glucocerebrosidase. It presents clinically with multisystemic involvement that includes the involvement of the major organs of the reticuloendothelial system, including spleen and liver, bone marrow, the skeletal system, and other organ systems that can be involved are pulmonary system and bone marrow and lungs. Additional feature and the risks include pulmonary infiltration or pulmonary hypertension, which is a complication in rare patients. In children, growth and puberty delay, and neurodegeneration, which is progressive in neuronopathic forms of the disease. They are termed neuropathic Gaucher disease that include the types 2 and 3, which we'll be discussing in the upcoming slides. As Dr. Dake iterated that it's the major risk for genetic is the major genetic risk factor for Parkinson and similar diseases in patients with type 1 Gaucher disease and other Gaucher disease carriers. Across all Gaucher disease types, the incidence estimates ranges between 0.45 to 25 in 100,000 live births. The incidence is lowest in the Asia-Pacific region. In US and other countries, developed countries, the incidence ranges between 1 in 50,000 to 1 in 100,000 for Gaucher disease. In Ashkenazi Jewish population, there is a predilection for the type 1 Gaucher disease due to the several mutations that are passed through. The incidence can be as high as 1 in 500 to 1 in 1,000. So in Europe, in North America, similarly, the incidence in 1 in 0.45 to 22.9 in 100,000 live births, and GD3 for in Asia Pacific only is 1.36 to 100,000 live births. There may be unique presentations of Gaucher disease that includes the cardiac phenotype that is deemed to be type 3C, and there is the Norbotian phenotype that is observed in the Baltic regions that is due to L44P or L483P homozygosity that is characterized by progressive cognitive changes. However, the presentation of Gaucher disease is quite variable among different ethnicities. The culprit for Gaucher disease or the deficiency of glucocerebrosidase is the pathogenic variance in the gene or called also GBA1 or glucocerebrosidase gene that is on chromosome 1. The gold standard for diagnosis of Gaucher disease is the direct sequencing. The reason is the gene also has a pseudogene that runs in the opposite direction and that causes recombinant events. Currently applied next generation sequencing panels that does not include less common variants in those targeted panels, including the molecular testing using the NGS panels that includes whole exome or whole genome sequencing that may actually lead to novel GBA variants that is not clinically determinant. These are the WUSs, and also the recombinant alleles arising from the GBA1 pseudogene that could be difficult to interpret. So also large deletions or large insertions could be missed in those panels that leads to erroneous prenatal screening results. In addition, although it happens in my practice to a handful of cases, there may be unique molecular genetic events that is especially observed in the hotspot of this gene. I have seen cases with uniparental isodisomy associated with other conditions, such as Charcot-Marie-Tooth, which is also on chromosome 1. I have seen chromosome 1 duplications, either partial or whole chromosome. De novo variants that one of the parents and the parents' actually extended family do not harbor the gene. And also we have seen somatic mosaicisms and multiplex in cis location that actually makes the interpretation of the molecular results quite difficult. So the other diagnostic tool is the use of biomarkers or lyso-Gb1, which is quite specific for Gaucher disease. The only problem with using a biomarker as a diagnostic tool is if it's not elevated, then it's not useful. So if it's elevated, it can be used as a diagnostic and also prognostic biomarker. So lyso-Gb1 or glucosylceramide is the component of cell membranes and the precursor of complex glycosphingolipids, which are very bioreactive. Lyso-Gb1 in the lysosome is the acylated form of glucosylceramide or GB1, formed by a metabolic pathway that is significantly active only in the absence of glucosyl GCase deficiency. So there are several hypotheses how the lyso-Gb1 can be measured in the peripheral circulation. First is when GB1 is deacylated into the lysoform in the lysosomal compartment, it becomes water soluble. So it can seep through the membranes. But the other alternative hypothesis that can include is the circulation from the dead or dying dysfunctional cells and tissues that are released through the macrophages. And the highest levels of lyso-Gb1 could be measured in the most severe form of Gaucher disease, which is the neuronopathic form, and with a specific emphasis on GD2 in newborns. The measurement of lyso-Gb1 can go up to a few hundred folds. However, while the few hundredfold elevation could be specific for the more severe forms, it doesn't distinguish between the two neuronopathic forms per se, which means that GD2 versus GD3. In the untreated obviously patients. So on the right side of the screen, you are seeing lyso-Gl1 concentrations for GD1 and GD2, GD3 patients. This is our data. As you can see, the GD2-3 actually can be over a few hundred folds over GD1. And the lower two graphs depicts the liver and spleen volume. Also, this correlates with the disease severity in the systemic as the severe in the systemic presentation of Gaucher disease. As you see, the liver and spleen volumes, as they get higher, also you get higher levels of lyso-Gb1. However, it is important to evaluate the biomarkers in the context of patient factors, obviously the age, the neonatal screening versus in an older patient, and also treatment status, treated versus untreated patients. In the untreated patients, it is quite valuable. Also, the disease factors that includes the disease onset, disease severity, duration, and rate of progression, and also the sample factors, whether it is done through using the dry blood spots versus whole blood. There is almost a 3 times difference between a dry blood spot and whole blood. Dry blood spot values are higher than the whole blood. Also, the collection and transport of the samples may affect the levels of the lyso-Gb1, including the laboratory factors, including the equipment that is used for LCMS. The normal values and upper normal limits can actually vary from laboratory to laboratory. So it would be apples and oranges to compare two different laboratory results.
So when I was diagnosed 20 years ago, the biomarker was not widely used. And the same with when Eli was born 18 years ago, it wasn't typically used. However, it's grown, and its usefulness, and it's not, and the ability to sort of track a person's progression or degression with the disease is amazing. And so one of the things that we learned with Eli is that every year he went to see a specialist, and using the biomarker, among many other diagnostic tests, of course, they did ultrasounds and DEXA scans and blood work. But in that blood work was the biomarker that sort of enabled the doctor to track the progression of the disease in his body. And so this sort of helped us all as a family and with the clinician determine when the best time to start treatment was which for us, he was 11 years old, and, he had an elevated biomarker. He was, showing some signs of enlarged organs, very minimal. He wasn't experiencing any symptoms yet, but based on those diagnostic numbers, we determined that it was a good time to start treatment.
When we collectively look at different GBA1 variants, there are more than 500 reported pathogenic variants that include missense, nonsense, insertions, deletions, frame shift, and in-frame alterations, and splice junction mutations. Among these, probably the missense mutations are the most common. And as I said, there are recombinant alleles arising due to to the recombination events with the homologous pseudogene. Examples of that, like such as REC-NCI, REC-T1, and there are complex recombinant events. These are named are through the southern blots that we do not use anymore, but through the next generation sequence panels, we get variants that belong to the pseudogene. So among these, N370S or N409S with the current nomenclature is the most common variant, which is also most prevalent in Ashkenazi Jewish type 1 Gaucher disease patients. And when we have this allele, we are almost certain that the phenotype is not going to be predictive of a neuronopathic type. So this is sometimes also called neuroprotective allele. However, pan-ethnically, when we don't take the ethnicity into consideration as far as Ashkenazi Jewish heritage is concerned, probably L44P or L4A3P allele is the most common allele worldwide. And the homozygosity for this allele is linked to neuronopathic Gaucher disease, and the patient will develop neuronopathic symptoms unless proven otherwise. I'm saying unless proven otherwise. The reason is there are some reports, patients with this genotype that is not reported to have neuronopathic symptoms. However, the presentation can be as mild as just the eye movement abnormality, which could escape from recognition, which could be very mild. I have several patients with this variant that they do have very mild eye movement abnormality, but otherwise they do have severe systemic involvement, but as far as the other neurological findings, they do not have. And then they do have, actually, they are functioning adults, so they are data analysts, lawyers, musicians, etc. And the homozygosity for this allele actually show diverse phenotypes, that the visceral phenotype is almost actually more uniform than the neurologic phenotype. There is severe visceral and skeletal disease that is observed unless the patient is treated early enough. And neurologically, there are mild cases with only slow saccades. The other milder variants that is pathogenic that include R49H or R535H with the current nomenclature, and the other probably milder alleles that are deemed to be the polymorphisms, such as E326K, that does not have a phenotype when is found actually in conjunction with another pathogenic alleles such as N370S. Okay, so when we look at the molecular changes, the cell biology of Gaucher disease and the downstream events that cause disease propagation with the hypothesis of mutant glucocerebrosidase leads to cellular dysfunction and cell death due to GL1 deposition, and the secondary events to the lyso-Gb1 that causes multiple pathway activation that relates to the immune events that ends up with the pyroptosis, necroptosis, and apoptosis. These are all collaborative cell death events. However, the clinical spectrum of Gaucher disease, as I said, is quite variable, and where null and severe GBA1 pathogenic variants result in very low GCase activity, and they actually are associated with Gaucher disease, and then two patients with two severe GBA1 variants are a combination of mild, moderate, and a severe allele. They are predicted to have severe disease. Patients with two missense mutations may not be always predicted to have the disease severity, whether they would develop a neuronopathic form versus non-neuronopathic form if the combination is especially with WUSs. So there are cellular genetic and there are other epigenetic factors that are still unknown to us, are actually the reason for this phenotypic variability. So, with this information given, clinically, the Gaucher disease is divided into two different clinical types, whether the central nervous system is impacted or not. So, these are the type 1, or sometimes is referred to adult onset Gaucher disease, which is a misnomer because this type also presents can early in the childhood. And the other type is the neuronopathic type, where the central nervous system is primarily affected. The neuronopathic Gaucher disease is further divided into type 2, which is the acute progressive form with death expected within 4 years of life. And the other one is the more common type 3 or chronic or subacute neuronopathic form. Thus, the neurologic manifestations of Gaucher disease can be actually towards from severe presentation and a bulbar involvement and death within few years of life to very mild asymptomatic patients neurologically. So these three pictures depict the severity of the spectrum. From the left-hand side, actually are included three patients with different involvement of the skeletal system. Type 1 becomes a major skeletal disease with significant morbidity, whereas on the right-hand side is the type 3 disease. And in between, in baby that is diagnosed with type 3, you can appreciate the massive hepatosplenomegaly of the child. So when we look at the neuropathology can range from a cell death from type 2 to asymptomatic patients, but also the subtype of Gaucher disease that is associated with Parkinsonian manifestations actually defies all this classification. And then we have the neuropathology from neuronal SANDET, which is extensively to a disorder that ranges to protein misfolding disorder. The prototype protein misfolding neurodegenerative disorders include synucleinopathies, and alpha-synuclein, which is a very small molecule, is primarily handled by the ubiquitin proteasome system and also lysosomal system. As we have seen in previous publications, there is a proven lysosomal dysfunction in Parkinson or Parkinsonian diseases with several lines of evidence. First is in the Parkinsonian models using the MPTP, which is a chemical. The lysosomes are seen to be depleted. And similarly, the lysosomal proteases are decreased in Parkinson disease brains. And also, lysosomal dysfunction is found in exosome-mediated synuclein release and transmission, and there is impaired autophagy caused by the synuclein mutations in the in vitro models. And similarly, lysosomal disorders are overrepresented in several Parkinson disease cohorts that is predominated by the GBA1 mutations responsible for Gaucher disease, and also SMPD1 variants that is responsible from Niemann-Pick AB. However, among all lysosomal disorders, Gaucher disease or GBA1 variants are predominantly the risk factor for the development of synucleinopathies and other Parkinsonism-related syndromes. So there are few hypotheses why this correlate association cellularly happening is basically there are two different hypotheses. One is the gain and the other one is loss of function. And the below are the lines of evidence that may support one hypothesis or others. So first one is the overexpression of GBA mutants raises human synuclein levels in vitro cell models. Actually, that is really significant, up to 250 times over. And in similarly in animal models, a mouse model of Gaucher disease that exhibits characteristic of synucleinopathies with accumulation of synuclein and ubiquitin positive aggregates in the hippocampal neurons, and similarly expression of exogenous glucocerebrosidase injected into the hippocampus of the GBA D409V homozygous mice ameliorates both the histopathology and memory alterations. So there is another hypothesis that actually marries these two hypotheses. So basically, there is the bidirectional pathogenic loop where the GCase depletion compromises the protein degradation and increases alpha-synuclein levels. In turn, the stored substrate glucosylceramide or GB1 stabilizes alpha-synuclein oligomers. And the third one is synuclein impairs in turn GCase activity. So basically, it becomes a vicious cycle. So a little bit talking about the GBA1, that is the hypothesis is misnomer that is named as the loss of function, what let's call this GBA1 haploinsufficiency. So on the right-hand side, you're seeing several iPS cell models where these benign or polymorphism are expressed, and they also lead some mild elevations in the glucosylceramide levels with the current techniques. So in the GBA1 haploinsufficiency model or hypothesis, there is reduced lysosomal GCase activity that in turn causes mild elevation in the GB1 and lyso-GB1 levels intracellularly or intralysosomally. That leads to lysosomal dysfunction, and also there is glucosylceramide and alpha-synuclein interaction that stabilizes further synuclein oligomers. That oligomers inhibit GCase activity and block GCase export from endoplasmic reticulum to the lysosomes. And there is further impaired autophagy, mitophagy, and mitochondrial function. These are the prime cellular events in synucleinopathies. Whereas the gain of function hypothesis emphasizes on the GBA1 variants and what supports this hypothesis, the carriers for GBA1 mutations, they do not never develop Gaucher disease, but they have major risk for development of Parkinsonian syndromes. So how this hypothesis goes is the primary reason for the development of GBA1 associated PD is the ER misfolding of glucocerebrosidase and activation of the ubiquitin proteasome system. That leads to the formation of actually the collection of the protein aggregates with the in turn degeneration of dopaminergic cells, lysosomal autophagic dysfunction, and eventually cell death. So we had known the association of the development Parkinson disease in patients with Gaucher disease with several case reports from 1990s. But this association and current the major risk factor for the development of Parkinsonian syndromes related to GBA1 variants has almost a 10-year delay for recognition. There are multiple reasons for that. First reason is probably Gaucher disease is much rarer than Parkinson disease. So it was not considered as a risk factor in these patients who develop Parkinson disease. And the genetic linkage deemed to be difficult due to rare variants in most data sets other than the Ashkenazi population. And the mutations have variable penetrations, and in some cohorts, they would only show weak segregation. And there is also the heterogeneity of the allelic variants. However, GBA1 association with the Parkinsonian syndromes came onto the radar because of the clinical observations, and the most work has been done in Dr. Ellen Sidransky's lab at the NIH. So there's several lines of evidence that supports this hypothesis. That includes obviously neuropathology, that is the strongest evidence for that. In the slide, you are seeing different sections from different brains from 7 patients who have Gaucher disease and or Gaucher carriers. Red depicts the staining for glucocerebrosidase, and green is the synuclein. As you can see, both Lilly bodies that are round protein aggregates with occasional halo in the middle. Glucocerebrosidase can be actually in the target regions. And also neurites, they both superimpose to contain both synuclein and glucocerebrosidase. And among these, E326K variant, as we know in the PD brains, is the most prevalent among the patients with also in GBA1-Associated PD patients worldwide. And this variant has been either deemed to be non-pathogenic polymorphism or very mildly pathogenic. So the other evidence, obviously, there are multiple families being published with this association. The passage of the GBA1 variant and the PD actually seems to be autosomal dominant in several families. And then we actually encounter family history of PD in several GBA mutation carriers, also in Gaucher patients. And the prevalence of Parkinson disease in GD carriers or non-carriers is 24% to 18%. And finally, in large cohorts, as is published in the New England Journal in 2009, there were around 6,000 patients with PD and also with controls. 20% of the Ashkenazi Jews and 7% of patients with different ethnicities carried GBA mutations. And obviously, the alleles that are frequent were the most common alleles, but there were also rare alleles encountered. When we do functional imaging in patients that have a high risk factor with either multiple family members or with the or themselves have signs or symptoms consistent with Parkinsonism, such as abnormal olfaction, tremor, or rigidity. We have actually performed PET scans using F18 DOPA, which is the marker of presynaptic dopamine turnover. And in these patients' brains, that is very similar. The dopamine loss was very similar to the distribution and extent in PD and GD-PD patients. And in addition, we did PET scans using the tritiated water that shows the decreased resting activity of the pattern, characteristics of diffuse Lewy body disease, which also is compatible with the cognitive changes in these patients.
Great. Thank you, Doctor, for that wonderful review on the molecular mechanisms leading to Gaucher disease. And I think that's a great segue to this next section, which will be focusing on Parkinson's disease and GBA-PD. So this section is called Guided by Genes, Advancing Screening, Diagnosis, and Treatment in GBA1-Associated Parkinsonism. So Parkinson's disease, we now understand, is largely a sporadic condition, but in about 10 to 15% of patients, there is a family history of disease. And we do think that for this small percentage of people, there may be a gene within a number of different genes that could be causative of their symptoms. The inheritance patterns of these genes causing Parkinson's disease can vary. It can be very much Mendelian, especially when we're talking about genes that have fully penetrant effects, both autosomal dominant and recessive. But it can also be quite complex in genes that have reduced penetrance, and certainly a situation that is hard to counsel our patients whenever they encounter that sort of situation. And then, of course, there might be patients who have sporadic disease, who have gene variants that we don't really know how to interpret. So it's just to say that the landscape of genetics within Parkinson's disease is expanding, and I think our understanding is continuing to evolve. So speaking about specific genetic forms of Parkinson's disease, we have a slide in this picture where you can see that there are different genetic forms that can cause Parkinsonism. On the top side of the screen, you can see the SNCA gene, also known as SNCA, which is the gene that encodes for alpha-synuclein. And mutations in this gene usually cause autosomal dominant Parkinsonism with very high penetrance. Contrast that to lower in that screen, the genes PINK1, DJ1, and Parkin, all of which are inherited in an autosomal recessive pattern. They do have high penetrance, so certainly they are Mendelian, but the phenotypes here vary. Although all of these syndromes tend to present earlier in the patient's life compared to sporadic Parkinson's disease, there are certain features that can distinguish between them. For example, patients with DJ1 Parkinson's disease tend to have early onset of cataracts, might have some hearing loss, and DJ1 has been involved also in immunomodulation and immune response. So it is possible that they might have a little bit of a different phenotype to those patients with PINK1 and Parkin, who tend to have much earlier disease presentation and not have any of these other associated features. Something else to notice, patients with Parkin mutations tend to have a lot of dystonia and tend to develop prominent dyskinesias when exposed to levodopa. Mutations in the TAF1 gene can cause X-linked dystonia Parkinsonism. This is a relatively rare condition that tends to happen in people from the Philippines, but essentially it is a neurodegenerative condition where patients start with a very prominent generalized dystonic picture that eventually over time it develops into a Parkinsonian syndrome. But let's focus in GBA. GBA is in this category of autosomal dominant mutations that have a low penetrance. And the low penetrance is what makes it so difficult to counsel our patients about their risks to themselves, but also risks to their loved ones. In fact, the penetrance is thought to increase with age, and it's been quoted that around the age of 60, the penetrance is somewhere around 15%, but that can double by the age of 80. So in folks who are carriers of these mutations, it's important to note that age is certainly the most important risk factor that determines the penetrance of the gene mutation itself. Also note how in Parkinson's disease, mutations in the GBA gene function as an autosomal dominant pattern, as opposed to what we heard about with Gaucher's disease when we think more about an autosomal recessive condition. Interestingly, the phenotype of patients who have mutations in GBA, Parkinson's disease with GBA mutations is a little bit different from what you would expect of patients with sporadic disease. These folks with GBA mutations as a group tend to have earlier onset, particularly homozygotes compared to heterozygotes, and certainly earlier onset compared to non-carriers. The disease itself seems to be more aggressive, not so much riddled by motor symptoms as it is by a heavy burden of non-motor symptoms. Importantly, there is early onset of cognitive decline, which can be quite challenging for patients and can actually lead to a reduced life expectancy. They do respond to levodopa just like they would in any other sporadic form of Parkinson's disease. And it's a little bit controversial about the effect that deep brain stimulation has for these patients. There is some literature to suggest that deep brain stimulation may accelerate postoperative cognitive decline in folks who carry mutations in GBA, although this is yet to be debated. Now, as we were learning before, there are different variants within the gene that can also lead to different phenotypes. So as we heard already, N370S is the most common gene mutation in Ashkenazi Jews, with a mild Parkinson's phenotype being produced from patients who carry this mutation. Contrast that to the form 884GG, which actually causes a very severe phenotype of Parkinson's disease in these patients. So it's interesting how even within a single gene, the variant does matter. And the area of the gene where the mutation is, as well as the type of mutation that is created, is going to really determine that severity of that Parkinson's phenotype. Note how E326K simply asks as a risk factor for Parkinson's and gives a mild phenotype, but is not associated with Gaucher's disease. So certainly a very complex pattern of inheritance that can also lead to a variety of different phenotypes. If we compare here a severe phenotype to a mild phenotype, and in turn to no GBA mutation, you'll notice sort of the theme that I've been mentioning, the typical age of onset, the more severe the phenotype, the earlier the age of onset tends to be. The rate of symptom progression tends to be much faster in patients with severe mutations compared to mild mutations. The level of cognitive impairment and how quickly the cognitive impairment develops, it's also much more pronounced in folks with severe mutation. And also the burden of non-motor symptoms with severe depression and anxiety, sometimes paralyzing anxiety that is very refractory to treatment. And as I was mentioning before, unfortunately, it does seem that as a group, folks with mutations in GBA tend to have a shorter lifespan compared to their sporadic peers. Now, knowing this, when should we test and who should be the patients that we should try to see whether they actually have a GBA-PD phenotype? Well, if there's a family history, of course, then that's easy. In general, we tend to offer genetic testing really to all of our patients with a focus on folks who have one or more first-degree relatives who have Parkinson's disease. But I think another red flag to suggest that a condition that a patient is experiencing could be genetic is the presence of early onset symptoms. So we usually think of ages before 50 as highly suggestive of a genetic form, whether it's GBA or some other gene variant. And if there's atypical features, I suppose if you have a patient who is not quite behaving like the way it should be expected, they're progressing much quicker, there's early onset of cognitive impairment, even in the absence of family history, I think genetic testing is certainly warranted and can be discussed. And how do we go about it? There's this nice paper that was published in Neurology in 2020 that provides us an algorithm of how we should think about genetic testing for these patients. So if you have a patient who is interested in genetic testing, and for those centers that have the capability, I think there's always a role to offer these patients research testing. The Parkinson's Foundation has a multi-center effort called the PD Generation Project, through which genetic testing is offered to patients in a remote manner. Patients are offered online genetic counseling and do have the option to have disclosure of their results. This is sort of a global effort to try to decode the different genes that cause Parkinson's disease. So we always encourage our patients to participate in research whenever they're willing. But of course, that is optional. And whenever you are faced with clinical testing, then there's this nice algorithm that can tell you how to go about it. So the first question to ask is whether the patient had an onset of symptoms before the age of 50. This, as I mentioned before, would qualify as early onset Parkinson's disease. And if so, then it would probably make sense from a cost-effective perspective to order a gene panel that certainly includes those autosomal recessive forms that are known to cause early onset disease. Parkin, for example, is a big one, PINK1, DJ1. In the absence of early onset, but with a positive family history, then those autosomal recessive forms are less likely, although not impossible. But definitely LRRK2 and GBA have a much bigger role, and whatever panel is ordered should make sure that should include these two genes. If the patient is Ashkenazi Jewish, then particularly LRRK2 and GBA have a prime importance and a high likelihood of being the culprit. Patients of North African Berber ancestry, LRRK2, there is a mutation within LRRK2 that is specific for this population. It is in the Western, in the Americas at least, a minority of the populations that we treat, but in the right geographic scenario, this is relevant. And whenever there is low risk or low yield, suspected low yield of having a genetic form of the disease, then a wide panel is usually the way to go to try to capture any possible genetic causes of the disease. So why test? What's the clinical utility of having a genetic diagnosis in the absence of targeted therapy? I usually tell my patients that there are several potential benefits. One benefit is prognosis. So we do know that folks who have certain GBA variants have a predicted more severe form than others, and it allows them to plan. I think particularly early on in the course of the disease, when there's a lot of uncertainty about what the future holds, it makes sense to have a grasp of what the potential disease course will be and how to plan accordingly for it. It also affects family members. Knowing that you are a carrier of a GBA or other mutation can certainly have repercussions to loved ones, siblings, children, cousins. So I think it's important to think about the impact that it might have to loved ones, and they might themselves pursue genetic testing. And then importantly, I think genetic testing is going to open us the window to test gene therapy trials. The inclusion criteria for these trials often suggest that patients need to have mutations in certain genes and sometimes specific variants within these mutations to be eligible for participating trials. And if we want to develop gene therapy, which mechanistically makes a lot of sense, I think the first step is to know your genotype. So there is utility in genetic testing, and it's something that we advocate for our patients, but it is ultimately a personal decision.
Genetic counselors play such an important role in our community, and I wish there was more of them because talking to families, they sort of see the entire picture. And in a way, they're like the middle person between the families and, the doctor who often only gets a few minutes, 10, 15 minutes with the family for each visit. But the genetic counselor, sees the entire picture and they're able to talk, about other types of services, social services, mental health, that really patients living with a rare disease, need to be able to access. And so, um, their role is so important. And when you have a good genetic counselor, it really you feel like you have a teammate on your side, because it makes all the difference. And you're able to share with them, and that they're going to relay your concerns to the clinician, even though he or she might only have a few minutes with you.
In this section, we're going to be talking about the collaborative pathways for personalized team-based approach for care for patients with Gaucher disease and GBA1 associated Parkinson syndromes. So let's review first the therapeutic approaches in lysosomal storage diseases with an emphasis on Gaucher disease. As we know, enzyme replacement therapy is the standard of care for many lysosomal disorders. And it completed its more than 25 years in the market. The idea that we're going to be actually discussing in the upcoming slides is through mannose receptor uptake and targeting to the lysosome, the exogenous recombinant enzyme. In addition to the enzyme replacement therapy, the other treatment options include substrate reduction therapy and chaperoning the misfolded protein to the lysosome using pharmacological chaperones. In several other lysosomal disorders, hematopoietic stem cell transplantation is an option. Now, currently, gene therapy trials that include in vivo gene therapy are actually in the trial. In the clinical protocol trial phase. Some of them actually is moving to the phase 3 studies. So let's talk about the currently the the therapeutic options that are currently in clinical trials but not approved. So there are for Gaucher disease. So there are a few in vivo gene therapy trials that are conducted. The currently enrolling one is Proceed with the SCT number 05487599. So it's a phase 1-2 multi-center 5-year open label dose finding study. The adults with peripheral manifestations with Gaucher disease that had been stabilized on either SRT or ERT, but still manifesting the disease signs of symptoms. So the primary outcome of the Proceed study is safety, obviously tolerability, and secondary outcomes are the change in the organ volumes and the hematologic parameters, including the platelet counts, the peripheral enzyme levels, and the lyso-Gb1 levels, and also the time to ERT and SRT discontinuation. The other in vivo AAV-mediated gene therapy trial, which is not currently recruiting, is specifically designed for patients with type 2 neuronopathic Gaucher disease. So this is a phase 1-2 multi-center 5-year open label dose finding study to include infants with GD2 from age 0 to 24 months. The primary safety, tolerability, and the immunogenicity of the AAV9 and the GKs in blood and CSF. The AAV9 vector that carrying glucocerebrosidase is directly injected to the cisterna magna in this trial. And the key secondary findings include time to death. As I need to remind, type 2 Gaucher disease is invariably has mortality. Clinical events such as the invasive ventilation, PEG-2 placement, and other developmental milestones.
So, one of the more recent discoveries in our community, although it's not so recent anymore, is the connection between Gaucher disease and Parkinson's. So the idea that you have a higher risk of Parkinson's is really important for our community to know because it extends to family members. And the reason that this is so important, obviously, you can't change the course of what's going to happen in your life, but you can maybe take certain health, you can make lifestyle changes to minimize risks. In addition, you could also begin screening tests. And so, what doctors in our spaces are doing is that for people that have Gaucher disease, they might begin screening for Parkinson's at age 50 now, where that was never a test years ago before we knew the connection. And so, the earlier you can catch these diseases, there's possibilities to slow their progression, or you understand how the progression of the disease is going to go for that patient. And so I think that spreading awareness about testing the types of Parkinson's when a patient presents with Parkinson's and is diagnosed, understanding the genetic background of that Parkinson's disease is really, really important. And then, of course, making the family aware that this is a genetic condition and that it could lead to other conditions as well.
Now, thinking about Parkinson's disease, we also have some exciting studies that are going on. This one is gene therapy. This study is called the PROPEL trial. It's a phase 1-2 multicenter 5-year open label study. And it is also gene therapy, as I was mentioning, through a viral vector. The vector is AAV9 that carries a copy of the GBA gene. It is also injected in patients via intracisternal injection. And it is an open label study, as I mentioned, so everybody gets drug. To classify for the study, patients have to have Parkinson's disease and at least one mutation in GBA1. That's to say that patients who have GBA and PD, GD and PD are candidates for this study. And the endpoints here are very exploratory and molecular. So the primary endpoint is safety and tolerability, immunogenicity, and the secondary endpoint changes in glycolipid, GCase levels, GK enzyme activity. And the study is currently recruiting and ongoing without any safety signals of concern. There's another study that is interesting to mention. It's the Activate study. This study has finished recruitment and is now in the follow-up phase. This is a phase 2 two-part dose finding study. The first part including genetic testing for GBA mutations, and then part 2 or part B was a double-blind portion of this drug that is a GCase activator, which means that it's supposed to rescue the function of mutant GCase. The outcomes here, unlike the PROPEL study, the outcomes here are clinical. So the primary outcome is time to clinically meaningful motor aspects of experiences of daily living, with secondary outcomes also related to motor function as well as quality of life in patients with Parkinson's disease. And there's a third molecule that is of interest in the PD space, and that's ambroxol. Ambroxol is a molecule, a small molecule that is CNS penetrant, and is actually available in Europe and elsewhere in the world as a expectorant. It's been available in the market for many years, but it's also been shown to have an effect on the function of GCase, and thus there are 3 different clinical trials in Europe looking at the effect of ambroxol in patients with Parkinson's disease. The first study is the ANCC study. That study has been completed. They demonstrated a 35% increase in CSA GCase levels and a reduction in UPDRS scores, so certainly promising. There's a second study, which is the Ambitious trial, which is ongoing. The primary outcome there is delay in progression of PDD to PDD, so Parkinson's disease dementia. And similarly, the GREAT trial, which is it's happening in the Netherlands, is also looking at whether cognitive decline can be slowed in patients with GBA-PD. So 3 molecules that are interesting and certainly more to come in the next few years. Now, a quick word on multidisciplinary care for patients with GBA-related synucleinopathies. Evidently, the complexity of these patients is such that the best care for this patient is really delivered in a multi-disciplinary approach. Certainly, we need neurologists and movement disorder specialists like myself, but we also desperately need more genetic counselors, availability of genetic counselors widespread to be able to guide our patients in the pros and cons of genetic testing. When patients are enrolled into clinical trials, that of course has now a separate arm of people who are on top of these patients' health and well-being. So that's an extra leg here, I would say, to that multidisciplinary team. But the needs of patients with GBA-PD is very varied, as I mentioned earlier. They have severe, significant, sometimes non-motor burden and such. They benefit from the input from psychologists, neuropsychologists, psychiatrists with specialty in the management of patients with Parkinson's disease, as well as physical, occupational therapists and social workers, particularly as cognitive decline sets in.
The idea of having a one-time cure for Gaucher disease is really it's a dream of many people, and especially the younger generations, that being told that when you're diagnosed that you need to have an infusion every 14 days, younger people, they want more. They want something better. They want to be done with their disease. And so right now we have several clinical trials in the space for type 1 Gaucher disease, which is really an exciting promise that you could take a treatment one time and then you could live your life and forget about your chronic rare illness. And then in terms of, the neuronopathic community, there's so much unmet need. And so just a treatment in the space, like having any type of treatment that can, cross the blood-brain barrier and make their quality of life better and allow them to live healthier lives, allow them to live full lives, is so important. And so any types of emergent treatments, whether they're gene therapy or small molecule or chaperone, we really hope for this community that there is going to be something available.
In this section, I'm going to present two cases. They are contrasting for Dr. Dake to comment on the GDPD with the information that we have reviewed and their eligibility, whether they are candidates for gene therapy. So the first case is a patient that present to our clinic at age 67 with a horn and yarn stage of this Parkinson disease at stage 2 with bilateral tremor. He was diagnosed with Gaucher disease incidentally during family screening. He is an N370S homozygote. His symptoms were very mild. He never required therapy. He developed a mild tremor in late 50s that spread recently to both sides. He doesn't complain about cognitive changes. He's still an active professional that runs his own business, and he doesn't have any neuropsychiatric symptoms. Whereas the patient below that presented to the clinic at the later stage of horn and yarn staging at stage 4. He had significant cognitive involvement. He currently requires help with his daily activities, and though he is mobile by himself, he cannot do his profession. As far as his Gaucher disease is concerned, he was diagnosed in late childhood. His mutations included 84GG and N370S. He requires splenectomy. Then he was treated all through his life with enzyme replacement therapy. He presented at age 43 with significant neuropsychiatric symptoms, severe depression and cognitive changes, followed by tremor and rigidity. So my questions for Dr. Date, could you please a little bit talk about GDPD and whether any of these patients, if they were living today, would be candidates for the gene therapy trial you're conducting?
Thank you. Yes, I think these are two very interesting examples, two sides of one coin, how even though it's the same gene, you can have very different phenotypes among patients. I think the latter patient, the second patient we discussed, probably wouldn't be a candidate for gene therapy because of his cognitive decline. But the first patient, if his motor symptoms were a little bit more advanced, could certainly be a candidate for some of the gene therapy trials that we have.
what are the some actually attractiveness or some points that the patients would like to have gene therapy for their PD in this scenario?
Yeah, I think in the PD space, certainly there's a component of it that is the prospect of benefit to the actual study participant, right? Like the fact that you could perhaps, if these therapies work, have for the first time disease modifying therapy in Parkinson's, which we currently do not have. But I think many of our patients, again, knowing that these conditions are familial, they have a sense of responsibility towards family members. I think in a way they want to make sure that other potential family members, nephews, grandchildren, sisters, brothers, don't have to go through what they go through. So I think there's a component of it that is certainly the ability to, well, if I can somehow contribute to the developing of these therapies that could avoid my loved ones from suffering like I've suffered, then I think that's a big motivation for some of my patients. So I think, I really commend the altruistic spirits of our research participants, because many times, and I would say most of the times, especially when they enroll in placebo-controlled trials, there really is no guarantee that any of these therapies are going to work for them. But I think they do see the greater good as worth it. Thank you all very much for attending our discussion. That brings it to a close for today. We certainly hope that you found the activity informative and useful to your practice. We do encourage you to access the supplemental program materials. And again, we thank you very much for participating today.
Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Gaucher Community Alliance. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/GWQ860.